What if I told you the single most critical data point for assessing your breast cancer risk isn't actually the age your aunt got sick, but the exact age your perfectly healthy uncle died?
Right, which sounds completely counterintuitive.
Totally.
Yeah.
I mean, it's almost morbid, right? But when you're trying to give your doctor a family history, the things you leave out are often the exact metrics they need.
Yeah, they need them to calculate your true genetic probability.
Exactly. So welcome to the deep dive. We have a highly practical mission today. If you are prepping for a doctor's appointment, how exactly should you prepare and document your family medical history?
Specifically, we're focusing on breast cancer, blood clots, and cardiovascular disease today.
Right. And we're synthesizing a massive stack of clinical protocols for this.
Yeah.
We're pulling from NICE guidelines, NHS Scotland risk assessments,
Mm-hmm.
OBGYN questionnaires, and even American Heart Association statements.
And the big overarching theme across all of these is that walking into a clinic and just saying, heart disease runs in my family, or my grandma had cancer, that's practically useless for a doctor.
Wow. Really useless.
Clinically, yes. The medical system requires a really highly structured blueprint of your bloodline. That's how they unlock specific treatment pathways.
Which is incredibly relevant if you're seeking things like, say, HRT for menopause,
Mm-hmm.
or trying to figure out if you need a referral to a specialist genetics clinic.
Exactly. You might think you know your family history, but the guidelines treat this like a rigorous investigative assignment. I mean, you really have to do your homework.
Okay, so if the goal is to build this hyper-accurate blueprint for your doctor, where do you actually start? Because I'm imagining just like printing out a giant ancestry chart with every second cousin and step-aunt.
Right, and you definitely shouldn't do that. That actually derails the assessment.
Oh, really?
Yeah, the clinical guidelines are ruthless about drawing boundary lines around who actually counts. People constantly bring up, like, a stepfather's heart attack or a sister-in-law's cancer diagnosis.
Because it feels like they're part of your immediate environment, right?
Yeah. Exactly, you live with them. But the absolute golden rule here is that all the relatives you report must be on the same side of the family, and they must be blood relatives of both you and of each other.
So it's kind of like a super strict VIP list for a club. Like spouses and step-siblings are just stopped at the door.
That's a great way to put it. If we're looking for inherited genetic mutations, the mutation only tracks through bloodlines.
Right, like tracing a bug in open source software, you don't look at the external programs the user installed. You have to trace the core code that was passed down.
Exactly. And they categorize this strict bloodline trace into degrees of separation, to weigh the genetic density.
Okay, so break that down for us. What's a first-degree relative?
First degree is your parents, your siblings, your children. Second degree expands out to grandparents, aunts, uncles, nieces, nephews, half-siblings.
And third degree?
That pulls in great-grandparents and first cousins. Basically, the further out the branch, the more diluted that shared genetic code becomes.
Okay, that makes sense. But looking at the NICE guidelines for familial breast cancer, I noticed they explicitly warn against this massive blind spot that, honestly, most of us have.
You're talking about the paternal history.
Yes. It is wild how many of us just mentally discount the dad's side of the family when worrying about breast cancer.
Right, because it's a female-dominant cancer.
Exactly. I've always assumed that, as a woman, my mom's sister's medical history is the priority.
Mm-hmm.
But the guidelines say my dad's brother's history matters just as much. Why is that?
Well, you inherit 50% of your DNA from your father. The genetic mutations that drive these aggressive cancers, particularly BRCA1 and BRCA2, they don't care about the sex of the carrier.
Wait, so they can just hide in a man?
Yes, they're autosomal dominant, so they can sit silently in a male bloodline for generations, just passed from father to son, until they're inherited by a daughter.
And then she has the tissue vulnerability to actually express that mutation as breast or ovarian cancer.
Exactly. A man carries the broken code, never gets sick, but passes the vulnerability straight down the line.
That is mind-blowing.
And this is why the NICE guidelines really highlight what they call a very strong paternal history. If you document 4 or more relatives diagnosed with breast cancer under 60 on your father's side, that's a critical trigger for a specialist referral.
Wow. So ignoring the men in your family tree literally cuts your genetic data pool in half.
It does. It artificially shrinks your risk profile.
Okay, so we know who belongs on the VIP list. But what specific data points are we pulling from them? Because I looked at these diagnostic questionnaires, and they treat this like a forensic timeline.
Yes, we're shifting from the who to the when. When you look at cardiovascular disease and blood clots, The risk assessment doesn't just ask if someone had an event.
Right, they want the exact age.
Yes, the exact age of the heart attack or the stroke.
And the Royal College of Obstetricians and Gynecologists emphasize this heavily for DVT risk, right? Deep vein thrombosis.
Very much so. If a first-degree relative had a venous thrombosis, your personal risk profile changes immediately.
But why the obsession with the timeline?
Because age of onset tells a completely different biological story. It's the loudest alarm bell for underlying genetic pathology.
Oh, I see. So if my grandfather has a heart attack at 85.
From a diagnostic perspective, that is largely the cumulative result of age, vascular wear and tear, and lifestyle factors over 8 decades.
Right, it's just getting older.
Exactly. But if your brother has a heart attack at 42, the mechanism is entirely different.
Because 42 is way too young for normal wear and tear.
Right. That early onset strongly points to an underlying genetic lipid disorder, like familial hypercholesterolemia or a structural coagulation defect that you probably share.
Okay, and the IE Quick Reference Guide applies that exact same timeline rigor to breast cancer. The risk categories just drastically shift based on the age of diagnosis.
They do. It forces you to categorize whether they were diagnosed under 40, under 50, or under 60.
And what's the significance of under 40?
Well, a single first-degree relative diagnosed with breast cancer under 40 is enough to warrant an immediate referral. Cancers that develop that early in life are bypassing the body's normal cellular repair mechanisms.
And those mechanisms usually take decades to fail, right?
Yes.
Yeah.
So early onset means those repair mechanisms were genetically compromised from birth.
Wow. Okay, this brings me back to that morbid detail I mentioned at the very beginning, the NHS Scotland guidelines.
Ah, yes. The healthy relatives.
Right, you're doing all this digging, you're calling relatives to find out exactly when your aunt was diagnosed. But the guidelines instruct doctors that they also desperately need the current age or the age of death of your unaffected close relatives.
They are looking for the denominator.
It is entirely a math problem. Like if I come into the clinic and say, I have 2 aunts who had breast cancer, the doctor's immediate reaction is alarm.
Right, but that's only the numerator. To calculate penetrance, which is the actual probability that a genetic mutation is actively ravaging a family, the clinician needs to know the total number of people who could have gotten sick.
Okay, so give me an example of how that changes things.
Sure, if they find out your father had 12 sisters, and the other 10 lived to be 90 with absolutely no cancer, your statistical risk drops significantly.
Because those 10 healthy women provide the baseline denominator.
Exactly. They prove that those 2 cancers were likely just an isolated, tragic roll of the dice, rather than a highly penetrant genetic mutation sweeping through the bloodline.
But conversely, if your father only had 2 sisters, and both got cancer at 40,
Then the denominator is tiny, the penetrance is massive, and the alarm bells are deafening.
nobody ever tells you to track the healthy people. We only ever document the trauma.
I know. But without the healthy relatives mapped out with their ages, the doctor just can't perform the true probability math. The assessment is incomplete.
That is so fascinating. Okay, so we have the timeline, the numerator, the denominator. But diving deeper into the familial breast cancer guidelines, you see, the medical system isn't just looking for breast cancer to predict breast cancer.
No, they're hunting for highly specific, seemingly disjointed clues.
Like bilateral breast cancer, cancer developing in both breasts. The guidelines state that does not count as one instance of the disease. It counts as 2 distinct flags.
Yes, because a cancer developing independently in both breasts, rather than just spreading from one to the other, suggests a systemic failure of the body's tumor-suppressing genes.
So the whole body is basically primed for mutation.
Right, rather than a single breast just being exposed to a localized factor. They also flag male breast cancer as an immediate trigger for a risk assessment, regardless of age.
Because male breast tissue is minimal, right?
Right.
And it's not subjected to those lifetime hormonal fluctuations like women are.
Exactly. For a cancer to develop there, it almost always requires a massive dominant genetic driver, usually a BRCA2 mutation.
We also see mandates to document Jewish ancestry. The sources note that individuals with Jewish ancestry are like 5 to 10 times more likely to carry BRCA1 or BRCA2 mutations.
Yeah, this is an essential piece of epidemiological data. It's a classic example of a founder effect.
A founder effect.
Yeah. Historically isolated populations like Ashkenazi Jewish communities experienced severe population bottlenecks centuries ago. A small number of founders carried a specific mutation, and because the population remained insular, it was amplified over generations.
Instead of being diluted into the global gene pool, that makes sense. But then the NICE guidelines mandate reporting what I can only describe as the weird cancers.
The anomalies, yeah.
Right. I mean, I get tracking ovarian cancer alongside breast cancer. They're both hormonally driven reproductive organs.
Yeah.
But the questionnaires demand you report sarcomas, specifically under age 45,
Yes.
and gliomas, which are brain tumors, and childhood adrenal cortical carcinomas. If I'm sitting in an OBGYN clinic talking about my breast cancer risk,
Uh,
and I bring up a cousin's childhood brain tumor, I mean, it feels like I'm wasting the doctor's time with a total tangent.
it definitely feels disjointed until you look at the underlying mechanism of what these genes actually do.
Okay, break that down for us.
So genes like BRCA1 and BRCA2 or the P53 gene, they are responsible for homologous recombination. Their entire job is to repair broken DNA strands and stop cells from dividing out of control.
They are the molecular brakes.
Exactly.
Yeah.
When those genes are mutated, the brakes fail, the error propagates, but that brake system exists in every single cell in the body.
Oh, wow.
Right. So when we see a cluster of sarcomas, gliomas, and early onset breast cancers in a single family tree, it points to overarching genetic syndromes like Li-Fraumeni syndrome. In Li-Fraumeni, the P53 tumor suppressor gene is broken globally.
So the childhood brain tumor isn't a tangent at all. It is the smoking gun proving the systemic brake failure.
Yes. If you only report the breast cancers because you think that's all the OBGYN cares about, you're hiding the actual pattern.
You're hiding the fact that the family is suffering from a much broader, highly dangerous genetic syndrome.
Precisely. You have to report the anomalies. The brain tumors and the bone cancers are the critical breadcrumbs.
Okay, that maps the cancer risk perfectly. But the source material introduces this fascinating collision. The genetic mutations might drive your cancer risk, but the treatments we use to manage menopause or even to treat those cancers drive completely different risks.
Yes, and this is why the cardiovascular and blood clot data you gathered suddenly dictates your treatment pathways.
Because hormones are powerful systemic messengers.
Exactly. When we introduce exogenous hormones like an HRT or when we artificially suppress endogenous ones, the ripple effect across the cardiovascular system is profound.
So let's look at the intersection of HRT, pregnancy, and blood clots. The Royal College of Obstetricians and Gynecologists highlights that both pregnancy and HRT naturally increase the risk of a deep vein thrombosis.
Yes, they alter the blood's coagulation cascade.
So if your newly mapped medical history shows that a sibling or a parent had a DVT, that genetic predisposition crashes right into the pharmacological risk of the HRT.
It compounds your danger significantly, and the risk profile flips completely when we look at cancer treatments.
This was heavily detailed in the American Heart Association scientific statement we read. They focused on patients taking hormonal therapy to block estrogen, which is like the gold standard for hormone receptor-positive breast cancer.
Right. The AHA notes that as these patients age on these therapies, they face a significantly higher risk of heart attacks and strokes.
Because estrogen plays a vital protective role, doesn't it?
Yes, it maintains the flexibility and health of the endothelium, which is the inner lining of the blood vessels. When an oncologist prescribes an aromatase inhibitor, or tamoxifen, to starve a tumor of estrogen?
They are simultaneously stripping away that cardiovascular armor.
Exactly. You are curing the cancer by starving it, but in doing so, you are rapidly accelerating the aging process of the heart.
It's like pressing the accelerator on a car. If your family history shows you're already driving on a really bumpy road of cardiovascular risk, combining that with an estrogen blocking therapy is like throwing gasoline on a fire.
Which is why the AHA strongly recommends proactive surveillance. If that cardiovascular family history is documented, it triggers baseline cardiology referrals or annual echocardiograms before the oncologist even begin the hormone blocking therapy.
Wow. The family history dictates the surveillance strategy. You have to know the structural integrity of the heart before you stress test it with the cancer treatment.
It's a very delicate, high-stakes balancing act between oncology and cardiology, and it's governed entirely by the data points in that family tree.
Okay, so we've built this incredibly detailed blueprint. We have the exact ages of the sick and the healthy. We trace the paternal bloodlines. We flag the brain tumors and the early heart attacks.
Right.
What is the actionable outcome here? How does the medical system categorize this data to unlock or restrict care?
The immediate outcome is risk stratification. The clinical guidelines use algorithms to place your data into a specific risk bracket.
According to the health and menopause literature, they look at 4 tiers, right?
Yes. Baseline risk means you reflect the general population up to a 17% lifetime risk of breast cancer. Moderate risk sits between 17 and 30%.
And high risk is 30 to 40%.
Right. And very high risk is anything over 40%, which almost universally points to a heavy genetic driver.
Okay, so what does that bracket actually do?
It dictates the intensity of your medical management. Do you stay in primary care with standard screening? Are you escalated to secondary care for annual mammograms a decade earlier? Or are you pushed to tertiary care into the hands of clinical geneticists for BRCA testing?
But this brings us to a massive misconception that the source material works very hard to dismantle.
Yeah.
Let's say you do the digging, you find the flags, and you land on that moderate or high-risk bracket.
Okay.
If you are struggling with menopause, the overwhelming assumption is that HRT is just permanently off the table for you.
Right, people think it's a ban, but the NHS Scotland protocols explicitly state that a family history of breast cancer is not an automatic contraindication to HRT.
Wait, really? Not an automatic ban?
No. The algorithms are designed to measure baseline risk, not to act as a punitive gatekeeper for quality of life treatments.
The sources provide vital context here. Because yes, taking combined HRT does carry a slight increase in breast cancer risk,
It does.
but an infographic from the British Menopause Society contextualizes that beautifully. It shows that lifestyle factors, specifically obesity and daily alcohol intake, actually drive up your breast cancer risk significantly more than a standard HRT prescription does.
This is the absolute versus relative risk fallacy in practice. We rarely see a physician outright refuse to treat a patient's menopausal symptoms because that patient enjoys a glass of wine with dinner or carries extra weight.
Good point.
Yet we see patients denied HRT constantly based on just a vague whisper of family history, even when the math shows the relative risk of the hormones is lower than the lifestyle factor.
So if you are mapping your family tree right now, and you find a history of breast cancer, the guidelines actually protect your right to access treatment.
Absolutely. The health and menopause guidance is clear. With a family history, you should generally still have all menopause options open to you, assuming you understand the baseline risk you're starting from.
Because there's no data suggesting that HRT acts as an uncontrollable multiplier, right?
Right.
It doesn't push your family history risk into an immediate guarantee of disease.
No, the baseline risk remains the baseline risk.
And the most empowering directive in these sources is that if a GP refuses to prescribe HRT solely based on the family history you documented, the guidelines explicitly advise you to seek a second opinion from a menopause specialist.
You use the very guidelines that stratify your risk to advocate for your access to care. You are no longer entering the clinic with a vague, fearful narrative. You're entering with organized, mathematically sound data.
It totally changes the power dynamic of the consultation.
It really does.
So to bring all these disparate threads together, the mission for you, listening, is clear. Limit your tree to blood relatives on the same side. Do not ignore your father's lineage. Track down the exact ages of diagnosis, but also secure the ages of your unaffected relatives to provide the denominator. Note the Jewish ancestry for the founder effect.
And flag those weird childhood tumors and sarcomas to expose any systemic genetic syndromes.
And finally, never assume a documented history automatically disqualifies you from treatments like HRT.
You are transforming anecdotal family lore into a highly precise medical instrument.
But as we close this deep dive, there is a fascinating, almost philosophical nuance buried deep in the NHS Scotland guidelines. They talk about something called the burden of proof.
Right. It really highlights the exact moment the medical system stops trusting the patient.
Exactly. Because if you sit in a clinic and report a family history of breast cancer, the doctor will generally accept your oral history. They log the aunt's age, they run the algorithm, they trust the family lore.
But the Scottish guidelines dictate that if you report those weird abdominal cancers or sarcomas we discussed, the lore is no longer sufficient.
Right. The doctor is mandated to verify those diagnoses with actual medical records, pathology reports, or death certificates.
The standard of evidence completely shifts from narrative medicine to forensic medicine.
Yeah, and it escalates even further. If your data puts you in the very high-risk bracket, and you decide to pursue risk-reducing surgery like a preventative mastectomy, oral history becomes completely obsolete.
Yeah, they won't just take your word for it then.
The medical system demands cold, hard paper receipts proving the genetic mutation. Or it requires the formal consensus of a multidisciplinary diagnostic team before they will allow the surgery to proceed.
Right.
It forces you to look at your family tree and ask, at what point do the stories passed down at the dinner table stop being a useful medical tool and start requiring the strict legal proof of a paper trail? You gather all this history to gain control over your medical future, only to find out that sometimes the only way the doctors will let you act on your own genes is if you bring them the paperwork to prove they belong to you.